I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Hey Sal, good morning. How are you?
Yeah, it's sat here actually in the dark and it's a beautifully sunny day. But it's so sunny in the room where we record this that actually you can't see me if I have the curtains open. So I'm in my cave, my sort of pod cave. Jam, how are you doing?
Pod cave. What, Sally, to be in a cave for our 1 year anniversary.
I know.
Can you believe it? March 2025, we started this and now this is episode 33 and we've done it for a year. So here's to our first year, and thanks to everyone that's listened and given us ideas and feedback and thoughts. But we're excited for year 2 and beyond.
We are, and a virtual chink of some fizzy wine of some sort to you, Jam, and also to all our listeners, and actually the great people we've worked with on this podcast as well. I think it's been really eye-opening, hasn't it? Just this whole new industry. So it's fab that we're still going strong. And just to reiterate, Jam, thank you to all of our listeners and all the feedback you've given us. It's been a really incredible experience. So yeah, it's been great.
It has. And today's topic actually has come from some of the feedback. We've had a number of emails and messages on social media saying, can you cover MRD? The 3 letters that are more common in my house are APT, but let's not get into Bruno Mars right now. But MRD, Sally, we're going to talk about minimum residual disease today.
Yeah, so MRD is something that many of our listeners would have heard of. And if they haven't, they'll be coming to their conversation soon. And that's why it's such an important topic for us to talk about. Now, we did, I think, touch on this in our sort of response pod, which we recorded some time ago, Jam, but we both felt, didn't we, a deep dive into this area is really important, not least so it's easier to find this information, but also it does warrant that, just to make sure we are clear in talking to our listeners about it.
Absolutely. And it's one of these things, if you go to myeloma meetings, you hear it everywhere. And it's very much the toast of the town and a topic that is at the front of everyone's thinking and imagination. And the reason for that is because our treatments have got so good. And we're getting to the point where we can treat people so effectively that it's actually hard in certain situations to see the myeloma there at all. Let's just talk about, again, very briefly, how we measure response, how people are doing in their treatment. And then that leads naturally to talking about measuring tiny bits of disease, the so-called minimal residual disease.
Yeah, absolutely. It's really important, isn't it, that in the majority of patients, we monitor the activity of the disease on their blood tests. And that's either by the paraprotein or the light chains or both. And when the myeloma is more active, those numbers that we measure relating to the paraprotein or the light chains go up. And then when somebody needs treatment and has effective treatment, those numbers should fall down. Now, of course, if the treatment works beautifully well, you might see the paraprotein completely disappear. That doesn't mean the myeloma is gone, because whilst we can talk about functional cure, sadly, the reality of absolute cure is not yet with us. And so the myeloma is flickering away there in the background, albeit at a far, far, far lower level. So beyond the sensitivity of our standard blood tests. And the same sort of applies for light chains as well. They might go back to within normal range. So they never disappear, but they can go to within normal range. But that doesn't mean that the myeloma has vanished. And so MRD, minimal residual disease monitoring, gives us greater insights into actually, when your blood tests aren't sensitive enough, what else can you do to find out how much of the myeloma is active within the body? And that's how I think about it, really. It's extra layers of information about the response.
Thank you, Sally. And how does looking at the bone marrow and people's scans fit into that framework?
One of the ways in which we diagnose myeloma is through doing a bone marrow test and trying to identify the culprit cells, the plasma cells, which are responsible for the condition, the myeloma cells. And you count them. And if you're above a certain threshold, you tip over into the diagnosis of myeloma. But of course, effective treatment should calm that down. So your plasma cells, your myeloma cells, should decrease. And in fact, sometimes if you look at the bone marrow, which is what we did, isn't it, in our training, you looked at it sort of down a microscope with your naked eye, you might not actually be able to spot that many plasma cells at all. And again, it doesn't mean that they're not there. It just means they're so few that the sample you've taken doesn't contain them. And MRD monitoring allows you to look for those plasma cells with a far sharper eye, better than the human eye, with far greater sensitivity to spot actually if every, 10,000 cells, 100,000 cells? Is there one myeloma cell that is present? And if there is, that tells us something. It might be that you can't even find that, which is fantastic. And that also tells us something. So that's the concept of minimal residual disease, is to spot those really small levels of involvement. And the only way you can do that, if there's nothing in the blood, is through going on the hunt in the bone marrow.
Blood tests are routine and done in a quite straightforward way, and a crude but initially very effective way at looking at response, and certainly looking at when the myeloma has come back. But potentially, when you can see it in the blood, it's already been brewing inside the bone marrow for a period of time. And, we will get onto this, but we're increasingly looking at ways as well of not having to do endless bone marrows to assess when tiny amounts of myeloma are coming back, which is a really exciting development. So when it comes to measuring MRD, Sally, at the moment, so minimum residual disease in the bone marrow, they're broadly sort of two main techniques, and these are done sometimes in any country. They'll have both techniques, and other countries have pioneered one over the other. I think just briefly, we should just, cover it, in relatively, simplistic terms, because they are slightly different and they have pros and cons.
Yeah, definitely. So two sensitive techniques, the first of which we commonly refer to as flow cytometry, or flow actually, we just abbreviate it, don't we really? Which is where you siphon off the myeloma cells once you've collected that liquid bone marrow sample. And then you look to find myeloma cells which are identical, because those identical myeloma cells are likely to relate to the abnormal component. And there will be background cells, plasma cells, which are the healthy ones, because we all have healthy plasma cells as well. And that you want to find out the ones which are identical or clonal. And this technique called flow cytometry allows you to do that through looking at the proteins on the outside of the cells. And then essentially you can count them, and you can see how many identical myeloma cells there are in your bone marrow sample compared to the rest of the sample. And that gives you a number, be that there's one cell, like I said, per 10,000 or 100,000. And that correlates to a level of sensitivity of this MRD sensitivity. So we say 10 to the minus 4, 10 to the minus 5, 10 to the minus 6, which correlates with 10 to the minus 4 is one abnormal cell per 10,000, 10 to the minus 5 is one abnormal cell per 100,000, and 10 to the minus 6 is where you've got one abnormal cell per million cells. So really not much going on there at all, but it is still present.
You've got all your zeros in the right place, Sally. I was just, impressed, like GCSE maths, high scores.
I know, good under pressure.
It was reminding me of my conversations this morning. What's more than a million is a zillion more than a gillion. But the fact that we're talking about, can you see one abnormally coated myeloma cell with these sort of protein signatures in a million is fantastic. And as the sensitivity gets better, we are going up those numbers, 10 to the minus 4, 10 to the minus 5, 10 to the minus 6. So that's flow. And historically, the UK has actually been very good at using that technique. And it's done across all hematological malignancy, and also is very important in lots of other conditions as well. So the second technique, NGS, so it's called next generation sequencing, really this relies on the fact that your myeloma has a unique sort of DNA fingerprint, and you're looking at that at the beginning, and then you're trying to see what happens to that fingerprint and whether it's still there in the future at various time points. So they're the two broad techniques. If you go on a clinical trial, now I have to say more of the time people are using NGS, but both techniques are excellent and are getting increasingly sensitive. Unfortunately, for the majority of people in the UK, it's only a tool that is used in research and is not used in routine day-to-day practice.
I completely agree. It is yet to be routine. And that's for lots of different reasons, I think, partly because actually the evidence is still emerging, isn't it, about what you do with these results when they are so low. But also, bone marrows aren't very patient-friendly, are they? And so actually, if someone's in a good remission and the myeloma is under control, what we need to understand is, well, if you're going to look for MRD, what are you going to do about it, and how frequently could you look for it? And at the moment, those questions remain unanswered outside clinical trials. But the reason this MRD piece is so important in clinical trials is that the responses to the new drugs are going on for so long. People are in remission for such a long time. If you actually wait to measure until their disease comes back, in some cases, you could be waiting for decades. And so what we do now, instead of purely relying on what we call that progression-free survival, which is how long it takes for the myeloma to come back after treatment, you can, at an earlier stage, look at how long does it take to get to MRD negativity, be that a 10 to the minus 5 or 10 to the minus 6. And that tends to go hand in hand with a longer period of remission or a longer period of your disease being under control. So it's really important in clinical studies because it allows us then to really understand these new drugs, how they work in which people and how effective are they at an earlier time point. And that's where it's really actually been game-changing as well.
A key point is that if people get to the stage where their myeloma is completely undetectable and they have this MRD test and their MRD is negative, so they have no detectable myeloma, what we know and what has been shown is that if you can sustain that for a period of time, which means repeating it again at some point, that is a very good thing. People who get down to that MRD negative level, their myeloma is under control for longer.
The lower you can go, so the sort of 10 to the minus 5 and the 10 to minus 6 is even better, or even 10 to the minus 7 in some studies coming through. The lower you can go in that measurement, oddly, the higher the number in the minus number. But the lower you can go in that measurement, the better, the deeper your response, the fewer myeloma cells there are in your body. And that goes hand in hand with your remission being sustained for longest, or rather your myeloma being under control for longest. So that correlates with a really good outcome, and particularly if that doesn't blip upwards, if the numbers don't change, as you said, Jam.
So for all the people up and down the country in the UK, and for our listeners abroad who are having treatment or even off treatment, and they're having their normal blood monitoring and they're on treatment, can MRD monitoring right now in 2026 impact how we're treating people, how we're monitoring people who are not on treatment? I think these are two really important questions that we should cover.
Yeah, absolutely. We're emerging into this new field, aren't we, really? When we're speaking about functional cure, and in fact, that's a podcast we did just a year ago, Jam, wasn't it? Our first podcast, we spoke about the concepts of functional cure, and it's become even more of a live issue over the last year. And I think when you're talking about functional cure, what you want is your myeloma to be under control, for that person to be living a healthy and a good life, and potentially, actually, off treatment. And so it might be that in the future that the clinical trials emerge and the data tells us that when you get to an MRD negativity point, you can change your treatment. You might be able to drop some of the drugs, or maybe even stop them and monitor it. And so this is what I would say is the new era that we're entering, really, is adapting the treatment according to those MRD results, which in some cases could potentially mean coming off treatment or certainly pulling back on it, which is, I think, really exciting. I think many of our listeners would appreciate that as a concept, just to lighten the load, really.
Okay, so I'm going to put you on the spot. You know, you mentioned this and someone is listening to this and they'll say, oh, Dr. Moore, I've managed to get my MRD tested. I found a laboratory, someone did a bone marrow and you can't detect myeloma. I want to stop my treatment. Is that fair? Is that reasonable? Or what else do you need to know? Because I think now we're having certain groups of people who have to be on treatment for significant lengths of time. And they're wondering, is there now a mechanism whereby it is safe? Because it's great that it's undetectable, but it's got to stay there, ideally.
To be honest, Jam, I am actually, frequently having these discussions now, not actually necessarily in the context of MRD, but with patients just saying to me, look, I haven't had a measurable paraprotein for 4 years. Do I really need to continue with this treatment? And I guess it's often a very complex and quite a nuanced conversation. But to really briefly sort of try and address your question, what goes through my mind is, okay, what type of myeloma does this person have? Did it affect their bones to begin with? Do I need to check that there's nothing going on in their bones? Did they have aggressive or high-risk cytogenetics, and therefore I might be more nervous about stopping treatment? How are they coping with the treatment? Are they getting nasty side effects? Are they able to stay on it? So they're the sort of crude sort of patient and disease-related factors that I'll be looking at least. And then in terms of the MRD piece, how deep is that MRD negativity? Is it 10 to the minus 5? Is it 10 to the minus 6? Has it been sustained? Have they held on to that negativity at least for more than a year? And then finally, okay, so it's sustained, it's deep, they don't have high-risk disease, their bones look like they're nice and under control. The next piece is, well, where is the evidence? We've always got to be guided by the evidence, because otherwise we're in uncharted territory. And if there is evidence to suggest that pulling back or stopping is there and it may be equally beneficial, I will share that. If it's a little bit more grey, I will share that it's grey. And then it's a discussion to have between us. So this is not absolutely black and white until we have the answers to these questions. But certainly if someone very much wanted to stop treatment for whatever reason, we could consider that, knowing that this is yet to be an exact science in the majority of cases. That's my very brief but somewhat long-winded answer. Thank you for listening to the Myeloma Minutes podcast, proudly partnering with Myeloma UK. For more credible myeloma-related material and support, please visit the Myeloma website at myeloma.org.uk. That's myeloma.org.uk. Or call the info line on 0800 980 3332, which you can find in this episode's description.
Just to pick out a couple of points, high-risk patients, so people unfortunately with genetically unstable disease, they can get MRD negative. The problem is keeping them there. And that is a real issue, and that whole area is under intense investigation. As you say, side effects. If you can't cope with the treatment, then there has to be a pragmatic quality of life question asked there. And of course, evidence. Increasing number of trials are reporting if you get MRD negative and you measure it again a year later, for example, you can stop a drug. Or if you stop entirely, this is what happens to people with certain types of myeloma. So every year we're getting those layers of information. But I think certainly for our UK audience, Sally, this does circle back to, it sounds like in the clinic we have a number of drugs and combinations now where people can get MRD negative, and that is a fact, certainly for frontline treatments and also certain treatments at relapse. We have the drugs, and the drugs are thankfully continuing to get better, but we can't routinely access MRD testing for these patients to help in these discussions.
I certainly agree. We've yet to ramp it up into standard clinical care, but it is really important to say, actually, one of our national clinical trials has just closed, the RADAR study, which is looking at offering different treatments to patients who are young enough for a transplant, depending upon their genetic risk, but also adapting their treatment according to their MRD negativity. And what's so exciting about that is it's more bespoke treatment, and it's tailoring treatment according to the response. And many other studies are doing that. And indeed, one of our colleagues, actually, Professor Karthik Ramaswamy, who's on the podcast around Christmas, he presented that data.
Friend of the pod.
A friend of the pod, yeah. He presented that data at our international meeting in the States just last year. And there'll be more and more data coming through from that trial and from other trials which are adopting this approach. And as that comes through, it will filter through to standard practice, certainly in the NHS and beyond. And therefore, it will, I suspect, in even 5 years' time, become something we do much more routinely to guide the treatments, when we stop, when we start, what we give, and so on and so forth.
It should be noted, we've been talking about marrow MRD, and, you're taking a sample from a specific part of the bone marrow. For many patients, that is representative of how their myeloma is. But you always have to beware of myeloma not being present in the area you take the MRD from, but there is an area of activity in other parts of the skeleton that you may only pick up on a scan. So imaging or scans, so scan MRD is an important part of the calculation as well, which is more of an issue for certain groups of patients.
Absolutely. And it's interesting that you raise this, Jam, because, just for us to remind ourselves about that lovely podcast we did with Mira, who spoke about her CAR T-cell therapy. And I'm sure you recall her explaining that actually her bloods were always okay. Her bone marrows were always okay. Yet her disease popped up in different areas throughout her body. And so for her, actually, doing MRD on the bone marrow wouldn't have been very useful. But actually doing the scans really told the story. And so there are some people who need one modality and not the other. But there are lots of people who need both. And by modality, I mean a bone marrow and a scan to really get a full picture that this person is MRD negative. And what that means in terms of a scan is where there was disease before, it's gone away, and there's no new areas of disease. And again, this piece is also evolving. What's the best way to measure bone disease on a scan? Is it with a whole body MRI, which isn't universally available? Is it a PET scan? Is it a combination of the two? But it's, whilst that debate continues, it's really important that we at least do that to get a full picture of what's going on within the person.
Another concept, Sal, that I think we should talk about, because again, it can be a bit confusing, is that you can still have a detectable paraprotein, so something you can detect in the blood, and be MRD negative.
Yes.
We should just it's a little bit counterintuitive, but we should just explain that a little bit. So essentially, the paraproteins are produced by these cancer cells, the plasma cells, but they have what we call a half-life. They take time to naturally go away in the blood. Now, of course, you kill the plasma cells, they stop producing more, but then your body just gradually degrades them. So the treatment can work so quickly now. Certain types of treatment, that is that you look in the bone marrow, you can't see the myeloma, but your body said, hold on, I haven't had a chance to actually completely get rid of the paraprotein yet. So I think that's just an interesting and slightly confusing concept.
Thanks so much for raising it. I think it really is confusing. And just to add an extra layer to that, different paraproteins, the IgAs, IgGs, the rare IgMs, leave the body at different rates. Light chains are whisked out of the body really quickly. The paraproteins linger for longer. And also, some of the treatments we give, like daratumumab, when you measure a paraprotein lab, it tells you there's a paraprotein there. And actually what it's measuring is the daratumumab protein, not the paraprotein. So, the numbers, again, to speak back to our last podcast, can be very informative, but sometimes they can lead you sort of down the wrong path and be a little bit confusing. So yeah, very important.
So at the moment, bone marrow is the main way in which we are getting the data for MRD. As we talked about a year ago, Sally, neither of us have had a bone marrow, but we've inflicted them sadly on so many people. But wow, if there was a way where we could just measure MRD in the blood, it would be fantastic. And these techniques are already being investigated very intensively, and in some parts of the world are being used routinely.
Yeah, absolutely. I mean, if we're still going strong, Jam, in 10 years' time on our 300th podcast, I suspect that we'll be talking about measuring MRD or just on blood tests alone. I really do think that it's a new frontier. It's coming. It's just yet to make it to day-to-day practice. But there's lots of laboratories around the world exploring this technique, whereby you can pick up a flicker of the myeloma at a more sensitive level on blood tests using something called mass spec or mass spectrometry. Bit of a mouthful. And again, I think when that does become more routine, we'll spend some time explaining it to our listeners, but just know at the moment it's out there, but it's experimental.
And we have a mass spec machine in Oxford in our research centre, which we're very excited to have. And there's lots of activity in trying to work out how to use it at what time points. And of course, intensively looking at the correlation between what MRD looks like in the blood and what you can measure in the bone marrow at the same time. But again, the move to everything being non-invasive is just a win for patients.
Yeah, definitely. I think on lots of levels, I hope the future looks bright for most of our patients in terms of the treatments, getting these deep MRD responses, these sustained responses and how we measure it, the stopping of treatment or the modifying of treatment. Hopefully they're all wins really, aren't they, in terms of just living a much more hopefully normal and therefore healthy life.
So Sal, what about MRD re-emergence and starting treatment? So at our recent meeting that we went to in Oxford, there was a very poignant patient story from someone not too dissimilar in age from us who unfortunately has, myeloma that is high risk, but he's been treated very effectively and he's now on a maintenance strategy. And he is MRD negative, but he's on a very intensive maintenance strategy. And he said to both of us, my myeloma is not detected, which is great. But as I understand it, I would need to have about 10% myeloma, or I would need to have proteins in the blood before my treatment would change. He worked this all out by himself without actually, I think, thinking about MRD. He goes, "What? But why wouldn't you just give me new treatment as soon as the myeloma became detectable again?"
Yeah, and this is a shift, isn't it, in our mindset, I think, the medical team and the medical community about treating myeloma. I think, style back sort of 10 years ago, we didn't really have we definitely didn't have as many treatments, and they certainly weren't as effective as they are now. And so I think at that time, there might be an argument for observing people as they slowly progress, if they were well and if they had no crab features, so that you use the treatment when it was absolutely necessary and not before. Whereas now the treatments are so good and there's so many more of them that I think that we're tilting very much more towards treating the myeloma as when we first detect it changing within the body. Now, because we're not doing MRD at the moment, we're not doing that when the MRD re-emerges. And by that, Jam, I guess you're referring to when you are what we call negative at 10 to the minus 6, let's say. So you can't find that 1 in a million cells. And then you do another bone marrow and you can, suggesting the myeloma is growing, albeit at a low level. At that MRD re-emergence. We're not testing at the moment, but we are testing, obviously, the paraproteins. And I think increasingly, when we see those paraproteins pop up, we're treating earlier because we know the newer drugs are likely to work better when you've got less disease in the body, but also you're going to get less toxicity, so you're going to be able to handle it much better. And I suspect, again, an area which we will evolve in the next few years will be, do we treat it MRD re-emergence? If you stopped a treatment, should you restart it again and see if you control it again? Or should you switch therapies? And a lot of that will depend on the treatment. It will depend on the nature of that myeloma, as you said, if it's high risk or not, and what the patient preference is, and of course, what the clinical study shows. So I think, again, that's a conversation which will evolve with time. At the moment, we're not doing that because we're not routinely testing that MRD, but it's logical, isn't it? It's come back. Get rid of it before there's too much of it in my body.
And we learn from other bits of hematology, right, Sally? There's this condition, chronic myeloid leukemia, which the treatment was transformed by, a tablet that became available, I think, 20 plus years ago now. But actually, this treatment makes people MRD negativity negative in that disease. It's measured. And again, if certain thresholds are reached, in lots of situations, treatment is reinitiated, as I understand it. I don't treat this condition day to day, but we learn from other areas of hematology where MRD has been in their mainstream for many more years. But we are getting there.
I think so. And it's unfortunate we're not yet able to do that in the NHS. I know actually, and both you and I look after a few patients in the private sector, Jam, and we have there's a little bit more liberty in looking after private sector patients in terms of the prescribing. And I've certainly adopted that approach with a couple of patients of mine, not according to their MRD results, but just according to the paraprotein results, and gone back in with similar treatment they've had before. And, this is a couple of cases. This is not a trial. This is not evidence. It's anecdote. But that, in those instances, has been able to calm things down. So I hope in the future that evidence builds so that we do have the liberty to do that. And especially because some drugs might really suit some patients. They might prefer drug X versus drug Y. And if it worked before, may it work again? Well, it might do. Let's try. Yeah, watch that space to see if that happens. It's a really important point.
MRD is already in the mainstream of myeloma doctors' brains. It's in the mainstream in all myeloma clinical trials. And I think importantly, for increasing numbers of regimens that we have available for our NHS patients, certain groups of patients are going to be going into what we call MRD negative remissions, undetectable myeloma. But we can't call it that because we can't measure it yet. But there's a lot of work being done at the moment in working out how MRD could be implemented across the country, because that is the future. And it's going to allow us to, as you say, tailor therapy, stop therapy, and maybe in due course, restart therapy. I think we all are nervous about stopping therapy too quickly, because if you've really got it under control and it's undetectable, it's like, don't rock the boat. But, as we get more confident with more data, better diagnostic tests, it's another step towards personalisation.
Definitely. It really is, isn't it? And also, it's another step to just minimising side effects. Some of the treatments we give, lenalidomide is a good example. People used to be on it for a few years and they'd stop because their disease would come back. Now, as maintenance, they might be on it for a really long time. And the longer you're exposed to it, the risks of side effects, potentially long-term side effects, do increase, albeit that it's a very low level. So to be able to get around those risks through stopping and starting would be fantastic. So I think a gain for all of us, really. Let's plan that podcast number 300, Jam, when we can talk about, the breakthroughs and mass spec and how it's all so terribly different.
We'll both be avatars by then, I think, Sally. But we can do it with our AI avatars. But Sal, it's been a great chat about MRD. Interesting, uplifting, and I hope everyone has enjoyed it. Guys, thanks for listening. I don't know if this counts as our anniversary episode, but it's been a great year and look forward to seeing you all at the next one.
Happy anniversary, Jam. Happy anniversary to all of our listeners and supporters.
Bye, everyone. See you at the next one. This has been the Myeloma Minutes. We hope you found this week's pod engaging, interesting, and above all, understandable and genuinely useful. If you enjoyed today's episode, please follow the podcast and share it with anyone who might benefit, from your online support group, your medical team, to friends and family. And as always, if you have questions or topics you'd like us to cover in the future episodes, please do get in touch. You can find us at www.themyelomaminutes.com or email us at themyelomaminutes@gmail.com. And you can find us on social media by searching the Myeloma Minutes on Instagram and Facebook. Many thanks for listening, and we'll see you at the next one.